Hello, I'm Dr. David Rubin. I'm from the University of Chicago Medicine, and I'm chairing an exciting meeting called Clinical Challenges in Inflammatory Bowel Disease, Exploring New Therapies. And joining me for this discussion today is my colleague, Dr. David Schwartz, who is Professor of Medicine and Director of the Inflammatory Bowel Disease Center at Vanderbilt. This meeting has been exploring some of the updates in our field of inflammatory bowel disease, starting with a really interesting keynote lecture about the microbiome and moving through some of our changing paradigms for management, understanding prognosis, and exploring therapy. In addition, the meeting included some discussions that were based on challenging cases, including a case on difficult perianal disease, a case of a patient with bad Crohn's disease during pregnancy, as well as a case looking at a refractory pouchitis, and lastly, dealing with dysplasia in IBD. So we've had a lot to think about, and we're very excited with the updates in our field and a lot for our clinician colleagues to know about. David, welcome to this discussion.
Thank you, David.
So you were part of a discussion about updates in the perianal management, and I thought that was really quite an effective and helpful educational session. Can you give the audience a little update regarding how we're thinking about perianal disease and Crohn's now, and whether some of our newer therapies can be applied to those patients?
Sure. I think the biggest change in the treatment of perianal disease is we're sort of applying the mucosal healing concept to perianal fistulas. So not just relying on symptoms, but actually using imaging to help kind of guide management and adjust our treatment algorithms based on that. We're excited about some of the new things that may be available. The introduction of vedolizumab may hold some promise for patients with refractory perianal disease, and on the horizon, maybe the use of adipose stem cells may be a benefit.
Yeah, so the adipose-derived stem cell treatment you mentioned at the end of your presentation, I think there was a lot of interest in the room. I even tweeted it. So where are we in that process? Maybe tell our audience a bit more about that.
Sure. So that's been in development for several years. Several different groups are looking at it, one in Spain and one in South Korea. Now there's a group, the group from Spain is looking at an allogenic model, the group from South Korea, autologous model. And no trials are underway yet in the U.S., but I think that there will be one hopefully getting underway in the next year or so.
Is a general concept that we're trying to just fill and close a fistula tract, or is it somehow breaking down the fibrosis and the scar tissue?
I think the concept is that those cells then differentiate into scar-forming cells and turn the fistula tract into an active scar and not an active fistula tract.
Right. Fantastic. So getting back to one of the other comments you made was just how to assess these and how we've been moving towards more objective measures of disease response. In the early days with infliximab, when it was being studied for perianal disease, you know, because you're also our expert on this, really that fistula closure was just defined as some light pressure and no drainage. Tell us a little bit more about how MRI or even endoscopic ultrasound is helping us.
Sure. So the trials initially were designed with a primary endpoint of just reduction in drainage with gentle pressure. It's a good clinical endpoint, but what we realized over time is that really there's still a lot of inflammatory activity present, and you can't see it. So the best way to assess that is to do MRI or endoscopic ultrasound, and we're realizing that that inflammation takes maybe 6 months to go away, so well after the time the drainage stops. So a number of groups, including ours, have looked at ways to use imaging to wait to that point where the tract is inactive, to pull the cetons, adjust therapy to really improve outcomes, and it seems to be working.
Yeah, well, that's very important. And that fed into some of the discussion I did in my presentation, which was really the changing paradigms in management, going from where we used to be in IBD, which was really crisis management and dealing with complications when patients came to see us, to thinking more proactively and chronically in our management strategies, starting with something like Dr. Cross or our friend Ray Cross talked about, knowing the prognosis of your patient, and then choosing therapies and then using monitoring tests to make sure that we're achieving our goals of treatment in a way that's going to provide longer-term success to all of these individuals. I also spoke about some of the changing paradigms we have now in terms of even thinking about the possibility of de-escalation or stopping therapies. There's been great interest in whether or not that's appropriate and how we would monitor patients going forward. One of the topics that came up today was on use of fecal calprotectin as a marker in IBD. Are you using that in your practice?
You know, I have to say I'm using it not as frequently as sounds like as most. We're actually using endoscopy more. Maybe I'm a little bit old school. But I do look at the data, and I think it's provocative. It's the problem of getting it paid for.
Right, as I mentioned. So in Chicago, we're having a little bit of difficulty. It seems like there's some regional variation in coverage. But the idea of using a fecal calprotectin in some patients, and it clearly is a better test for people with colitis than maybe for small bowel disease, but as a way to not only know if somebody has inflammation versus irritability, but also as a way to assess response to therapy or loss of response or recurrence after surgery in Crohn's, for instance. So I think people are excited about it, but we have to learn a bit more about how we might incorporate this into practice.
I think it'd be helpful if we could get an office-based assay rather than having to send it off and wait for the results to come back. With that real-time results, I think that'll be tremendous.
Yeah, so at the end of my lecture, as you recall, we talked a little bit about how some of this may actually become at-home monitoring for patients, and also how clinicians may have what's called a personalized genomics array for patients, so we can actually assess pharmacogenomics too and know more about how to choose therapies. You're going to be discussing further today 5-ASAs and steroids. So what's up in that area of our management?
Well, it's the title of my talk is "Say Hello to an Old Friend," because we've been using both of them obviously for decades. I think one of the things that you highlighted this on in your talk is whether or not we have to keep people on the same dose we use for induction and maintenance. And I think we trained around the same time. It was sort of driven into our head that the dose needed to get people in remission is what you need to keep them on to stay well. And now we're really realizing that may not be the case for people that can achieve mucosal healing. So that's exciting.
Yeah.
And one of the things also is the controversy of whether or not the 5-ASAs make a difference in colon cancer in patients with ulcerative colitis. And this obviously data very well. We used to use that as one of our ways to keep people on medication, and now we're having to sort of eat our hat a little bit and rethink that question.
Yeah, the newer studies looking at 5-ASA as part of a cancer risk assessment seem to have a less robust prevention possibility, maybe because the older studies didn't control for one of the most significant variables, which was degree of inflammation. So as soon as you address that, the benefit from a chemoprotective point of view with 5-ASA seems less. It may not be completely gone, though, because as you know, there's some compelling models in animals and others. What about with steroids?
Well, steroids obviously probably one of the more common things used to treat both ulcerative colitis and Crohn, especially acute disease. Excitingly, we have a new budesonide preparation that works in the colon. We're I think still struggling to figure out where best to use that agent, but it gives us the opportunity to get some of the benefits of steroids without some of the side effects of prednisone. Yeah,
so that's a good segue into another theme from today's meeting, I think, which is the change from using systemic therapy for everything to understanding a little bit more about some of our new options of using more organ-specific treatment strategies before we go to systemic. So this whole concept of where might you position a therapy like a colonic delivery budesonide prior to prednisone, for instance, or even IV steroids, and also our newer biological therapies, the anti-integrin therapies, which target the leukocyte trafficking to the bowel, and how we might think about using those. Where do you position that? Is that best positioned after TNF hasn't worked, or is it positioned earlier? I hesitate to say we should position it anywhere, because one of the main messages today has been all about individualizing therapy and understanding your individual patient. So maybe there's an older patient in whom risk is too high for some of our systemic therapies, or who has already demonstrated an allergy to other drugs, or a younger patient who has limited disease where you're going to think about something differently. So one of the messages for our colleagues has really been about know your patient, and whichever treatment strategy we start with, don't just wait to see what happens or until they have a complication. Use some way to assess disease response, which is a recurring theme here.
My experience has been, when we started, it was hard to get patients to have repeat colonoscopies when they were feeling well, and I think now that message is out, and I think patients are buying into it and actually asking, when am I going to have that repeat assessment to make sure this medicine's working?
Right. And I always say that when you're offering patients repeat assessment, you have to be careful, because that can be a double-edged sword. Because when you tell them that our goal is to heal the bowel, the first thing they usually say is, wasn't that always your goal? And then the second thing that happens is, if you look and you haven't healed it and you make an adjustment to therapy, what if you can't get there? So if the patient's expectation is that their bowel is going to be healed or healing, and then we look again and we're not getting there with adjustments and therapy, how far do you go? And that's a real challenging topic. So on the surface, it's easy to say, well, yeah, we should treat to this target of healing or something like it. But the reality may be that perfect may be the enemy of good enough. And we have to realize where that edge is for a lot of people. Yeah. But there's low-hanging fruit that makes a lot of sense. So our colleague, Dr. Fernando Vallejos, is giving a nice lecture updating us on dysplasia management. Are you using chromoendoscopy in your practice?
Yes, I am. We're reserving it more for the high-risk patients or people that have had some abnormal biopsies in the past.
Yeah. And which dye do you prefer?
Well, methylene blue, at least in our institution, seems to be the easiest to get. So,
right. So there is actually a national shortage right now of indigo carmine. But many of our colleagues in Europe and elsewhere have favored indigo carmine over methylene blue. I actually prefer methylene blue as well. But we should just be clear on this for our audience, which is that indigo carmine is a surface dye. Methylene blue is an absorptive dye. So there is a distinction there. And some people have some concerns about the possibility, although not proven, of carcinogenic or DNA damage with methylene blue. I think for intermittent and appropriately used dilute methylene blue for chromoendoscopy, that risk seems very, very low. And in my experience, it sounds like yours, it's a superior dye. It really just gets absorbed beautifully. You don't have to rely so much on gravity, and you can see a lot. I'm not using it in everybody either. I use it in people who've had previous dysplasia who've been referred to me for further assessment. I use it in our higher risk patients like PSC. And of course, you want the patient to be clean and to be as much in remission as possible in order for this to even make sense. There was a consensus meeting earlier this year that I know Fernando will speak about, and which I was part of as well, that tried to look at some of these questions. And one of the important gaps that remains is the distinction between high definition colonoscopy and whether or not adding chromo makes that better. Because the older studies of chromo where it showed that you could find more dysplasia were all with standard definition scopes. So I think for the audience watching this discussion, the message is that chromo clearly does have a role in some patients. I think people need to be familiar with it. They certainly need to be thinking about it for their patients who've had dysplasia or who are at higher risk. But they should stay tuned for more consensus and guidelines that are coming.
And I think one of the barriers, at least initially when we were incorporating this, was the time.
Yeah.
And now with being able to put it in the water bottle and sort of streamline things, it's almost the same time as with regular surveillance colonoscopy,
Sure.
maybe even quicker.
Maybe the last topic we can talk about is the newest therapy that has been approved for Crohn's and ulcerative colitis, vedolizumab. So I've already mentioned briefly the concept of these leukocyte trafficking inhibitors and anti-integrin therapies. Have you been using any vedolizumab yet?
Yeah, we were part of the studies, and we've incorporated it now in our practice, and now that's available.
Yeah, so us as well. Since it became available post-marketing, where are you using it?
So for ulcerative colitis, I'm actually giving patients the option of that or an anti-TNF if they're in the moderate severity. For Crohn's, I think right now, for the time being, we're still using it more as after TNFs, but that's open for reassessment.
Right. I think with any new therapy, we have a whole group of patients who are not doing as well on existing treatments, where we have an obvious place to plug it in. Thinking about how it might be used in the future is something we need to be thinking carefully about. Patients are intrigued by the option that it has what looks to be an organ-specific strategy, although we should be careful that we know that it's still a protein-based therapy, so there's still the risk for immunogenicity, and that it does extend the mucosa that it affects extends up into the sinus area, and that's something else to know about. Nonetheless, this is a new option which our patients definitely needed, and I think we're all excited to have some more to offer our patients.
Definitely.
Great. Well, I want to thank you for this really great discussion and for being part of this meeting here in Chicago, and I'll look forward to having you here again next year.
Thank you, David. That was my pleasure.
Great. So thank you for joining me for this discussion here at the Chicago meeting, Clinical Challenges in Inflammatory Bowel Disease and Updates in Emerging Therapies. This has been a great meeting with wonderful faculty, and perhaps you'll be able to join us here in Chicago for the next meeting. Thank you.